have one lecture from Professor B.N. Mishra, whom I met him recently in Jaipur conference as well. And Professor Mishra has very readily agreed to talk to us again. And this time he's going to talk on a very, very important practical aspect of internal medicine training program, that is mimicker of SI elevation. And many times in your OPD or in your ER, you find a person presenting to you with chest pain or otherwise, but has an elevated ST. So, and you may mistakenly diagnose him as acute coronary syndrome. But what are the other mimickers which can actually give you a false positive hope or at least diagnosis? What Dr. Mishra is going to talk to us about for next 45 minutes or so. And Dr. Mishra is a well-known authority. He is a professor of medicine and HOD in All India Institute, Bhopal, and he has various publications and donations. So over to you, Dr. Mishra, for your presentation.
Thank you, Dr. Singh, for your kind introduction. So I'm going to talk on how to recognize imitators of ST elevation as told by Dr. Singh. We all know that ST segment elevation is a common ECG finding. ST elevation can be found in patients presenting with or without chest pain. And in a good number of these patients, the ST elevation is not due to an acute myocardial infarction. This is very important. I'm saying that ST elevation in a good number of patients may not be because of MI. Many diseases could imitate ST elevation as caused by an acute ST elevation MI. And that is why it becomes extremely important to know that what are the diseases and how we can differentiate non-ST elevation or ST elevation because of other than MI. The ECG may look like an ST elevation MI and it may mask other etiologies. We will discuss some clinical and ECG interpretation techniques for identifying ST elevation MI mimics. Now, before going to that, one has to understand how to see the ST segment. The level of the ST segment should be measured in relation to end of the PR segment and not the TP segment. Why I am saying this? Because in this way, ST segment deviation can be detected accurately even when TP segment is not nicely visualized in conditions such as when P wave is superimposed on the T wave during sinus tachycardia, when PR segment is depressed, and when a prominent atrial repolarization wave, that is TA wave, is present. So it is better that we compare ST segment elevation with PR segment and not the TP segment. And this is the classical representation of a normal and an ST elevation situation. Now you see the PR segment and the TP segment. TP segment is the end of the T wave and the beginning of the P wave. And PR segment is end of the P and beginning of the QRS. So this is a better baseline for interpretation of the ST segment elevation. Now, second important thing before going for ST segment elevation condition is the concavity and the convexity of the ST segment. Now, you see here there are two situations. In both situations, ST segment is elevated, but in one there is a concave elevation of the ST segment, which we are seeing that is represented here, and in another there is a convex elevation of the ST segment. You are seeing I'm moving the cursor and you can see this is a concave elevation, although there is a significant ST elevation, but because of this concavity, this is not significant, and this is a convex elevation of the ST segment from the J point. Now, before going for conditions which can mimic, let us see what are the normal ST segment elevation and normal variants. Now, you will be surprised that a good number of young healthy individuals, they have ST segment elevation in lead V1 or rather in lead V2. In a study on more than 6,000 men in US Air Force between 16 to 58 years of age, 91% had ST segment elevation of 1 to 3 millimeter in one or more precordial leads. Elevation was most common and marked in lead V2. So this is a surprise for many of you. In a recent study of the similar kind, which was done on nearly more than 500 men, ST elevation of at least 1 millimeter in one or more leads V1 to V4 was seen in 93% in men which were 17 to 24 years of old. It declined gradually with increasing age, reaching 30% in 76 years or older. In contrast, only 20% of the normal ECG from women have ST elevation of 1 millimeter or more, regardless of the woman's age, meaning thereby that normal ST elevation, and that is why this is known as a majority of the young healthy men have ST elevation of 1 millimeter or more in precordial leads. It is a normal finding, even not a normal variant, and is designated as a male pattern of the ST segment elevation of less than 1 millimeter is designated as female pattern. So if in a young healthy individual of maybe 18 or 20 or 25 years, ST segment is elevated, but this is having a little concavity, not a convexity, which I will show you in coming slides. The ST segment is concave in these ECGs. The deeper the S wave, the greater the ST segment elevation, a relation that is often observed in patients with left ventricular hypertrophy as well. So majority of the young, normal, healthy individuals, they can have ST elevation in one or two of the precordial leads. And that is why this is to be kept in mind while interpreting ST segment elevation. This is again diagrammatical and ECGical representation of the ST segment elevation, which is normal. Then there is a normal ST segment elevation, which is known as normal ST variant. In some young black male, we are fortunate that this is the racial kind of thing, and this is mainly seen in the young black men, and that is why in many of these young black men, it is very difficult to diagnose an infarct because it could be a normal variant of the ST segment elevation. Now you are seeing below the ECG, which is practically looking as an infarct ECG, yeah, right? You are seeing in the precordial leads a significant ST elevation, which is just like infarct, but this is a normal variant. In some young black men, the ST is elevated in the mid-precordial leads in combination with a T-wave inversion. This entity may be combination of an early repolarization and a persistent juvenile T-wave pattern findings are suggestive of acute MI. Echo is necessary in this condition to differentiate. QT interval is short in this patient, where it is not short in acute MI. Pericarditis. This condition or this normal variant differs from the early repolarization pattern in that the T waves are inverted and ST segment tends to be coved. There is one more thing which I referred in this slide also, and that is early repolarization, right? Now, does it really matter whether it is ST elevation or there is no ST elevation or it is only just imitator? Yes, it does. Now, here you are seeing a replica of the famous painting Girl Before the Mirror by the Pablo Picasso. But you see, the original is original and replica is a replica. Why this is important? Because in few studies on patients treated with thrombolytic agent, it has been found that nearly 6 to 11% did not have infarction and they have been given thrombolytic therapy. Incorrectly identifying ST elevation imitators as ST elevation MI leads to inappropriate management and use of resources, especially of the great concern is the inappropriate cath lab activation, which negatively impacts limited resources. Majority of the false cath lab activations are the result of unrecognized imitators. Now coming to the real issue of what are the conditions which have got a imitator kind of presentation. And luckily we have got a mnemonic which is just nothing but elevation. Here you are seeing the conditions, they start from E, L, E, V, A, T, I, O, N. So elevation, if you remember elevation, you will be able to remember the important conditions which may cause imitators of ST elevation MI. I will go one by one. E stands for early repolarization. I will be coming to this in the subsequent slides. L stands for left middle branch block, which is a very important imitator of ST elevation MI. E stands for electrolytes and especially hyperkalemia. V stands for ventricular hypertrophy, that is LVH, which is the commonest cause of imitator. A stands for aneurysm, which is nothing but ventricular aneurysm. T stands for Takotsubo-cardiomyopathy, which is a relatively newer entity, and even the Bargada syndrome, which is also known as Thailand syndrome. I stands for inflammation, that is pericarditis. O stands for a rare condition known as Osborne wave, which is because of hypothermia. and N stands for non-ischemic vasospasm. So this mnemonic of elevation is nothing but the common conditions which are going to be imitators of ST segment elevation. Now I will go one by one to these conditions, and subsequently I will summarize in the last. Now coming from E, that is early repolarization. What is this? This is known as benign early repolarization, or BER. This is the most common benign ECG pattern, especially in the young healthy athletes. Incidence of this finding may be as high as 5 to 13%. There is widespread concave ST elevation in the precordial leads, which may vary from V2 to V5. You are seeing a representative diagram along with the most marked in V4, rarely in the limb leads. Notching or slurring at J point, which is known as fish hook appearance. So you see this blue arrow which is showing the J point notching. This is known as fish hook appearance. And here you are seeing the concave ST segment elevation of significant amplitude, but this is a concave ST elevation. This is known as smiley face. It's a smiley face ECG. ST segment elevation from baseline in V2 to V5 typically maybe 3 millimeter as high as 3, but this is a concave ST elevation, and this is because of early repolarization. Large symmetrical concordant T waves in lead may be again present in these patients. This is again the same full ECG from V1 to V6, and what you are seeing, early repolarization of the atrial tissue is also present. And this leads to resulting in PR segment depression. Here you are seeing the PR segment is also depressed. This is the PR segment. And if you see, this PR segment is also depressed. So in benign early repolarization, you can see even the depression of the PR segment. Asymmetrical T wave which are concordant with the QRS. Concordant means with the same site where the QRS is there. This is the concordant T wave. The QRS is here and T wave is here. This is again concordant T wave. Discordant means if this T wave polarity would have been opposite to the QRS, then this would have been a discordant T. The degree of the ST elevation is modest in comparison to T wave amplitude, less than 25% of the T in V6. The T waves are tall and they are not inverted. So this is the classical ECG of benign early repolarization. There is a tall tented T waves, which is less than 25% of the R, and of course the PR interval is also, the PR segment is also depressed. Now this is yet another ECG of benign early repolarization, or BER, but one should be cautious in diagnosing BER in patients who are above 50 years of age, because many times you may think in terms of BER and it may be infarct. No reciprocal ST depression to suggest ST elevation MI except in AVR. Changes vary with the heart rate and are more prevalent at the lower heart rates. ST changes are relatively stable over time. That means there is no progression of the serial ECG tracing. So if this is a ECG of benign repolarization, then it is going to remain same on day 1, day 2, day 3, day 4, and maybe on day 6 or 7. While in the ST elevation MI, it will sequentially change, which all of us know. Now coming to second important condition, that is left ventricular hypertrophy. Now this left ventricular hypertrophy, most common cause of ST elevation MI, that is nearly 25%, is mimicker is this left ventricular hypertrophy. LVS does not always have ST elevation MI. QRS voltage pattern helps in determining LVH versus ST elevation MI. And how it is done is, this is a 3-step method. Step 1, step 2, step 3. So if you are having a confusion, what you should do is go for step 1, that is height of S wave in V1 and R in V5 or V6 if it is more than 35 millimeter. Then go to the step 2. Step 2 says R wave in AVL is more than 11. Here you are saying this is AVL, and this AVL, I am putting cursor here, is nearly 12 or 13 millimeters in height. So this is fulfilling the step 2. R wave in AVL is more than 11. If yes, then move to step 3. And step 3 says strain pattern, that is ST depression and T wave inversion in V5 and V6. If all three criteria are met, that means step 1, step 2, step 3, if all three are being fulfilled, patient has LVH with ST elevation MI, and not ST elevation MI. That means this ST elevation is because of LVH and not because of ST elevation MI. One of these criteria in isolation of the other two does not eliminate ST elevation MI. So LVH could be easily differentiated from so this is one of the imitator, but this could be easily differentiated by this three-step test. Second important differentiator, which sometimes is really difficult, is left bundle branch block. Now, all of us know that the diagnostic criteria for LBBB are QRS duration more than 120 millivolt, that is in V1. So you are seeing this red circle is indicative of that. Broad notched R wave in AVL, V5 and V6. This is you are seeing AVL. This is V5 and V6. The broad notched R, and absent Q waves in AVL and V5 and V6, and prolonged R wave peak in V5, V6. Prolonged means more than 60 millisecond. So this is classical left ventricular left bundle branch block. Now, left bundle branch block, the difficulties in diagnosing AMI in patient with left bundle branch block, they come because abnormal ST morphology and T wave polarity, which is discordant to the QRS. Discordant means opposite to the main QRS complex is discordant. Alter the T wave and the ST segment changes usually associated with ACSO. In acute coronary syndrome, whatever we get, because of this phenomena of discordant ST segment changes, they are difficult to appreciate. Patients with bundle branch blocks have concurrent coronary artery disease and are at higher risk of developing ischemia. So this is a very difficult situation because LBBB patient is likely to have acute MI, and at the same time it is difficult to diagnose with acute in presence of left bundle branch block. It is difficult to diagnose that MI is there or not. So there is a criteria known as Garbosa criteria. This was original Garbosa criteria, which I will tell you right now, and then it has been modified by the Smith. So Smith's modification of the Garbosa criteria. And what this criteria says, there are original three criteria used to diagnose infarction in patient with left bundle branch block. And these are concordant ST elevation, that is more than 1 millimeter in leads with a positive QRS complex. So if there is a positive QRS complex lead, just like a lead AVL, and if there is a ST elevation of 1 millimeter, then it gives a score of 5 to this finding. If there is a concordant ST depression, that is more than 1 millimeter in V1 to V3, it gives a score of 3. And excessively discordant means opposite to the main QRS complex. ST elevation gives 5, which is more than 5 millimeter in leads with a negative QRS complex gives a score of 2. And these criteria are specific but not sensitive for MI. A total score of more than 3, equivalent to or more than 3, is reported to have a specificity of 90% for diagnosing myocardial infarction. So if you carefully look for these three criteria, so three findings, 1, 2, and 3, and the score, that is 5. If it is 5 score, means even the solitary single finding of this 1 millimeter ST elevation in concordant ST elevation, then this will be suggestive of left bundle branch block. I will show you in the coming ECG how this behaves. And now this is the diagrammatic representation of the original Garbosa criteria, where you are seeing this is the discordant ST segment in the T waves, and this is the Garbosa criteria where there is a concordant, and I will show the real ECG in the coming slide. Modified Garbosa criteria has been done by the Smith. So there is a Smith's modification, and what this modification says, the most important change is in the excessive discordant use of more than 5 or 5 millimeter cutoff, which has been taken off by this Smith modification, which was, according to Smith, was arbitrary and non-specific. So patient with left bundle branch block and large voltage which have ST deviation more than 5 in the absence of ischemia, the modified rule for the STMI is discordant ST elevation with amplitude 25% of the depth of the preceding S rather than minimum 5 millimeter. So rest of the criteria, they remain same. One lead with more than 1 millimeter of the concordant ST elevation. This was in original criteria, Garbosa criteria. One lead of V1 to V3 with more than 1 millimeter of concordant ST depression. This also remains as it is. But third criteria is change in the Smith modification, and this is one lead anywhere with more than 1 millimeter ST elevation and proportionately excessive discordant ST elevation as defined by more than 25% of the depth of the preceding S wave. So this is what is the modification of the Barbosa criteria by the Smith. Now here you are saying this is the beautiful ECG where this criteria is being fulfilled. Here we are seeing this is the lead AVL which I have circled by blue circle. And what we are finding, there is 1 millimeter, clear 1 millimeter ST elevation in this lead, which is concordant. So this concordant 1 millimeter ST elevation in presence of left ventral branch block will diagnose infarct. So this patient has got a acute myocardial anterior wall infarct in presence of left ventral branch block. Rest of the findings, they are suggestive of LVBB. And because this finding is there, so this is suggestive of LVBB with infarct. Now, positive Barbosa criteria in a patient with left ventral branch block and troponin positive MI. Again, I am going to tell you some narration here and then show the ECG. Patient presented with chest pain and had elevated cardiac enzymes. ECG showed typical left ventral branch block. Now, there is 1 millimeter concordant ST elevation in AVL. So this is the description of the earlier ECG which I have showed you, where there was elevation of 1 millimeter in AVL. Other features of this ECG that are abnormal in the context of left ventral branch block but not considered positive Barbosa criteria are pathological Q waves in lead 1 and the concordant ST depression in the inferior lead, that is 3 and AVF. So these were also present, but these are not part of the Barbosa criteria. This constellation of the abnormality suggests that the patient was having a high lateral infarct. So this was an ECG with an infarct in presence of left ventral branch block. This is yet another positive Barbosa criteria in patient with ventricular paced rhythm. Because I have got limited time, so I will not be able to tell you each and everything in details. But in this ECG, you find this is a paced rhythm, and here the Barbosa criteria is being fulfilled. And how it is being fulfilled has been shown in this ECG. Now coming to second, pericarditis. Pericarditis is widespread concave ST elevation and PR depression throughout most of the limb leads. So the characteristic of pericarditis is that there is widespread concave ST elevation and the PR depression throughout most of the limb leads, 1, 2, 3, AVL, AVF, and precordial leads which may vary from V2 to V6. Reciprocal ST depression and PR elevation in leads VR and V1. So here we are seeing this lead V5 which is showing this narration which I am telling you. Sinus tachycardia, which is common in acute pericarditis due to pain and or pericardial effusion. Yet another condition which I told you in your mnemonics was electrolyte imbalance, and hyperkalemia is the most important electrolyte imbalance which mimics acute myocardial infarction. Hyperkalemia as a cause of ST elevation is well known. Elevated ST segment is often downsloping. Now this is one of the important feature, that this ST elevation, which is just like a camel hump, this has got a downslope, and this is nothing but hyperkalemic ST elevation. A finding that is somewhat unusual in the acute MI, whereas ST segment has a plateau or a shoulder pattern or is upsloping. So in the ST segment, you find an upsloping ST segment keeps on going like that, and here you are finding it is coming like this. And so this is suggestive of hyperkalemia. Other ECG features of hyperkalemia often present are widened QRS complexes, well-pointed and tented T waves. Here we are seeing the tented T wave, and low amplitude or non-P wave. So P wave is also absent in this ECG. The full lead is not visible. And echo can be extremely useful in this situation. Coming to LV aneurysm, following acute anterior MI without adequate reperfusion, we know that up to 60% of patients will develop left ventricular aneurysm, that is LVA, which manifests as persistent ST elevation. So if a patient comes who had earlier history of MI, and this time when he comes to your ICU or emergency setup, you find that ST is elevated and this is looking like an ST elevation MI. Then how to differentiate this situation, which is because of left ventricular aneurysm, from acute MI? While left ventricular aneurysm may be detectable by echocardiogram. So echocardiogram is the easiest tool by which immediately you can find out that this is nothing but the aneurysm. The presence of one does not rule out acute MI. But even then, the acute MI may be present in presence of aneurysm also. Therefore, the question becomes what ECG findings can help differentiate between the two processes. So there are certain ECG suggestions which I am going to tell you right now. Acute MI usually has larger T waves than left ventricular aneurysm. This is one. So T waves, they are larger in acute MI than left ventricular aneurysm. If any one lead in V1 to V4 has a T wave amplitude to QRS amplitude ratio greater or equal to 0.36, then ST elevation MI is predicted, which has got a sensitivity of nearly 92% and a specificity of nearly 82%. So what do you mean? That when you are seeing such a situation, you look for the amplitude of the T wave. If any one lead in V1 to V4 has a T wave amplitude to QRS amplitude, that means the ratio between T and QRS greater than 0.36, then this is suggestive of ST elevation MI rather than LV aneurysm. Now this is the ECG of LV aneurysm. Here you are seeing that although ST is elevated, but the ratio between this and ST elevation is not fulfilling the criteria of more than 0.36. So this is LV aneurysm rather than acute MI. One relatively uncommon condition, although we see stray patients every now and then, is Takotsubo cardiomyopathy. Takotsubo cardiomyopathy term is derived from Japanese word takotsubo for the traditional ceramic octopus trap, which is also known as apical ballooning, stress-induced cardiomyopathy, or broken heart syndrome. The more common than previously thought accounts for nearly 2% of ST elevation MI in USA. This is more common in postmenopausal elderly women, but can occur in other groups as well. Patients tend to present with symptoms which are similar to acute coronary syndromes. An emotional or medical trigger, such as loss of a loved one or severe pain or medical illness, is usually what we see as a preceding history. History is an important aspect in the diagnosing of Takotsubo syndrome, as over half of the patients with Takotsubo have psychological or neurological disorders compared to only 25% of those with acute coronary syndrome. Because even ACS also, there may be the precipitating factor may be a stress or sudden loss of near and dear. Now this is the classical differential from which is done by angiography. Patient have ECG changes including T wave inversion, ST depression, or sometimes ST elevation, elevated enzymes, and apical hypokinesia. So they have got all features suggestive of acute MI. LV angiogram in diastole, you see here left, and this is systole right. In right anterior oblique projection demonstrating wall motion abnormality, which is characteristic of the stress cardiomyopathy, which is having this hump here where it is suggestive of, this is the suggestion of Takotsubo cardiomyopathy, which could be confirmed on angiography. Left angiogram is the confirmatory. Now the word about Brugada syndrome. In 1992, Brugada described 8 patients with history of cardiac arrest and ECG findings of right bundle branch block and ST segment elevation in the right precordial leads in the absence of long QT interval, any structural heart disease as well. Brugada syndrome accounts for 40 to 60% of all cases of idiopathic ventricular fibrillation. So this is a very, very important condition in clinical practice. This syndrome has been linked to mutation in the cardiac sodium channels gene, resulting in loss of the action potential dome in the right ventricular epicardium, but not in the endocardium, creating a transmural voltage gradient that is responsible for ST segment elevation in the right precordial leads and genesis of VF as well. So here we are concerned with how this could be used as a differential. Now here you are seeing this is characterized by ECG abnormalities. In some incomplete right bundle branch block is present. In others, the high take of ST segment mimics the pattern of right bundle branch block, but the wide S wave in lead 1, AVL and V6 that are typically seen in right bundle branch block are missing. So this is not a classical right bundle branch block. Few of them, they may have complete or incomplete RBB, but in others where the mimicker of MI may be there, this is suggestive of the ST segment mimics the pattern of right bundle branch block, but the wide S wave in lead 1 and AVL and V6 are typically seen in the right bundle branch block are missing. So this is the Brugada syndrome. The ST segment elevation is limited to leads V1 and V2 and can have a saddleback shape in typical cases. So this could be just like here you are saying it is a saddleback ST segment elevation. It begins from the top of the R wave, is downsloping and ends with an inverted T wave. So this makes the saddle. So this is the saddleback kind of elevation of the ST segment. This pattern is so distinctive that it should not be mistaken for acute infarction. So this is a very classical picture, saddleback kind of ST elevation in anteroseptal infarcts complicated by right ventral branch block. The downstroke of the R' wave and the beginning of the ST segment have a distinct transition, and the ST segment is horizontal or upsloping and not the downsloping ST segment. So in few, this could be like this, where the ST segment may be horizontal or upsloping, but not a downsloping ST segment. The ST segment elevation in the Brugada syndrome may be present continuously or it may be present intermittently. So both kind of ST elevation may be there. That means it may be in multiple leads or it may be in the few leads. One more differential is pulmonary embolism. Pulmonary embolism can cause a pseudo-infarct pattern, which could be a manifestation of the pulmonary embolism. ECG features, they include T-wave inversion in the right precordial leads, T-wave inversion, ST segment elevation, or both in the anteroseptal and the inferior leads. A classical pattern which is known as S1, Q3, T3 pattern. S1, Q3, T3 pattern. Complete or incomplete right bundle branch block and sinus tachycardia. I will show the ECG in the coming slide, which will make it still more clear what is this S1, Q3, T3 pattern. Now this demonstrates sinus tachycardia, prominent S wave in lead 1. So this is what is S1, prominent S in lead 1, right? You are seeing here, this is prominent S in lead 1. So prominent S in lead 1 with Q wave and T wave inversion in lead 3. Q wave and T wave inversion in lead 3. So lead 3 has got Q and a T inversion is also there. That is what is known as S1, Q3, T3. So Q3, T3 here in 3, lead 3 and S1 here with inverted T waves in V1 to V6. And along with that, there may be inversion of the T from V1 to V6, which we are seeing here classically. So this is suggestive of a pulmonary embolism. So the sign, ECG sign is known as S1, Q3, T3 sign. Osborne or J-wave is, we hardly see this because we are not living in a country where the freezing temperature is quite often seen. But hypothermia of more minus 30 kind of thing, 30 degree Celsius is associated with presence less than 30 with presence of Osborne or J waves. Positive deflection at J point, bradycardia, including AV block and atrial fibrillation, they are also common in moderate and severe hypothermia. Hypothermic patients are at risk for ventricular fibrillation. So this is not much of our concern because we will hardly encounter this phenomena. Non-ischemic vasospasm, which is coming in a big way in recent years, especially because of this drug cocaine, which is Europe and America, a good percentage of patients are being seen with this infarct kind of pattern. ST elevation pattern is that of an injury current pattern, but has a different mechanism and different management as well. Cocaine-induced ST elevation secondary to vasospasm should be treated with benzodiazepines and nitrates as needed. While it is possible to have a ST elevation MI from a ruptured plaque and subsequent clot formation in a patient with cocaine toxicity, it is helpful to risk stratify patient with a suspected STMI by age, risk factors, etc. It may be impossible to tell by surface ECG, and therefore, without a left heart catheterization, if the stimulation is due to a cocaine toxicity or due to a plaque rupture. So this is one of the situations where it is extremely difficult, because this nearly mimics 100% cocaine consumption, and acute cocaine consumption may mimic ST elevation MI nearly 100%. And only thing which differentiate this is from left heart catheterization. So left heart catheterization will be required. History is of course very important. If there is history of consumption of cocaine and the patient has been retrieved from the drug party and he has symptoms suggestive of MI, then this differential diagnosis has to be kept in mind. And so the scene of history becomes most important. Now coming to the summary of ST segment imitators, this summary could be seen like this. Normal so-called male pattern is seen in 90% of the healthy young men. 1 to 3 millimeter concave most marked in V2. So I have told you in the very first slide that up to 90% of the healthy young individual, they may have 1 to 3 millimeter concave ST segment elevation, especially in the lead V2, which should always be kept in mind, because this is what is known as normal male pattern. Then ST elevation of the normal variant could be there, which is seen in V3 to V5 with inverted T waves, short QT and high QRS voltage. But we are lucky that we are not having black population with us, because this is mainly a racial observation, and that is why we are not very frequently encountering this kind of situation. Early repolarization, of course, we do encounter. This is most marked in V4 lead, notching at the J, which is a fish hook kind of appearance, tall upright T wave, reciprocal ST segment depression in AVR, not in AVL, when limb leads are involved. This is what differentiates it from early repolarization from MI. Left ventricular hypertrophy, as I have told you in detail, that three-step procedure of voltage criteria, concave, other features of left ventricular hypertrophy, which I have told you in detail. Left ventral branch block has got concave ST segment deviation discordant from the QRS. So concave ST segment deviation and discordant from the QRS, these are the two important things which one has to keep in mind. In acute pericarditis, diffuse ST segment elevation, reciprocal ST segment depression in AVR, not in AVL. Elevation seldom more than 5 millimeter. PR segment depression is again a feature of this acute pericarditis. Hyperkalemia, widened QRS and tall tented T waves, low amplitude or absent P waves, ST segment usually downsloping. Brugada syndrome, RS-RDS, which is right ventral branch block pattern in V1 and V2, ST segment elevation in V1 and V2 typically downsloping, and that is what differentiates it from a routine infarct. Pulmonary embolism changes simulating MI seen both in inferior and the anteroseptal leaf. And classical, I have already told you, V1 lead 1 is having S and lead 3 is having T and distance. So 1 Q3 phenomena, which I have told you in detail. ECG is the mainstay of diagnosing ST. So coming to the conclusion, what conclusions we can draw? ECG is the mainstay of diagnosing ST elevation MI, which all of us know. And this is a true medical emergency as well. Making the correct diagnosis promptly is life-saving. Several conditions can be associated with ST elevation on ECG, most commonly LVH, left ventral branch block, pericarditis, early repolarization, and so on, which we have discussed in great details. If the clinical picture is consistent with MI and the ECG is not diagnostic, serial ECGs at 5 to 10 minutes interval, they might help in making further comment whether it is MI or it is non-MI. Some of these conditions should be misdiagnosed as acute infarction, resulting in unwarranted thrombolytic therapy, resulting in emergency angiography and even sometimes angioplasty, or rather alerting the cath lab for angioplasty. In few studies of consecutive patients treated with thrombolytic agent, it was found that nearly 6 to 11% patients did not have infarction and they were about to be primarily intervened. So it is extremely important to confirm the diagnosis before starting the treatment. The shape of the ST segment elevation, the lead involved, other features of the electrocardiogram, clinical setting in which the elevation occurs, and most importantly, the awareness of the condition that mimics infarction can help differentiate this condition. In addition, of course, use of biomarkers remains the most important differential, because as you know that infarct is diagnosed only when biomarker is positive, and echocardiography can be very, very helpful. So bedside echocardiography and use of biomarkers is the real differentiator between a classical ST elevation MI and non-ST elevation mimickers. So this is all I have to tell you. Thank you very much for your patient listening.
Thank you, Professor Mishra, for giving a very, very clear-cut depiction of what are the mimickers of ST segment elevation, and you have pointed out almost all differential diagnosis. And also, you have pointed out, I think the last statement was very, very important. It's a combination of the clinical presentation with ECG changes and biomarker elevation, which can help us to delineate whether we are dealing with the acute coronary syndrome or not. Though many a times biomarkers can also be elevated in myocarditis, especially the anxiety-induced myocarditis or other conditions in which myocardium is injured. But definitely, I think most of you attendees must have learned a lot, and there today the record attendance of 219 students were there. So my question first is to there is a condition known as pre-excitation syndrome or WPW syndrome. Now that can also sometimes mimic ST segment elevation or some sort of a STT changes, and the presence of WPW syndrome makes a patient very vulnerable, especially in the presence of atrial fibrillation. So, do you think that can also be uh, counted as a mimicker of ST segment elevation?
Yes,
Or a specific?
you are absolutely right, sir. There are many more situations, but I have tried to include only very, very important and very, very common situation. But for this last situation, that is the cocaine, which we
Yeah,
hardly encounter in India, which is mainly a concern in the Western countries and the Europe. But majority of the condition which I have included, they are of day-to-day importance. And so, early postgraduates who are about to become physicians and maybe they will be dealing with acute MI. So that was the main contention. And
I
because
think
in one lecture of 45 minutes covering other
yeah,
rare conditions becomes very, very
and
difficult.
absolutely clear cut presentation on the 6-7 differential diagnosis. But trainees, I think you must remember that any patient who has a pre-excitation syndrome, if he develops atrial fibrillation, this was one of the queries, then it can be very dangerous because the
You are absolutely
fibrillatory
right.
waves can actually go through the shorter pathway, and the conduction can occur through shorter pathways, and it can convert into a ventricular fibrillation. And there is no blockage of the AV node which protects us from the ventricular rate. That's very, very important. So hemodynamically, the patient will be very unstable.
Absolutely
One,
right, sir. You are
yeah,
100%, you are 100% correct, sir.
yeah.
You are
One
absolutely
question
right.
is on potassium level, hyperkalemia. Yes, that can also cause tall T waves, and that can mimic. One interesting question is, can acute pancreatitis cause ST elevation? Definitely, it can irritate the myocardium and also can cause pseudo elevation. Anything which is happening below the abdomen, below the diaphragm can also mimic and can cause sometimes presentation. People are complimenting you for your crisp presentation. And so pericarditis, ST elevation, a smiley face or inner mind? There's a question, sir. In pericarditis, is the ST elevation a smiley face or in the mind?
No, no, it's not smiley face. It is different.
Okay.
It is
So
different. A smiley face is classical repolarization ECG, which is mentioned as a smiley face.
and in pericarditis studies, the ST changes are there throughout the limbs, not on
Yeah,
the specific.
yeah, exactly, exactly.
So, and then there is, of course, they're asking you about ST elevation. Brugada is it upsloping or downsloping? So
What is
Brugada, he did show that there it looks like an RBA piece, and So, sir, any pointer on that? In the Brugada, is the ST elevation upsloping or downsloping?
No, it is usually downsloping, sir. That is
It's not.
classical downsloping ST, and that is one of the differentiating point between Brugada and classical ST elevation MI. ST elevation MI usually ST segment has a tendency to go up. It is not having a downslope. While in Brugada, it just goes up and then there's a hump-like downslope, which is what makes it different. Yes.
So someone has asked about what are the strain patterns in OVH. I did answer, but you can also answer them. Strain patterns are STT changes which occur along with left ventricular hypertrophy. And that is why we call it as a strain pattern. And if you have a criteria fulfilling the LVH, then the STT changes which are accompanying that will be known as strain pattern.
Exactly, sir.
So I think many of your questions have been answered. Can we differentiate what is the stroke patient show ST elevation and AF? Is there any need to treat, sir? Definitely, stroke can get
Stroke
precipitated.
patient, they have more of ST segment depression rather than elevation. Although sometimes rarely one can see some minimal elevation as well.
But
But
if we have
generally,
atrial fibrillation, then we must anticoagulate them. No? AF is a risk factor for stroke. Student asked that these patients may show ST elevation and atrial fibrillation. But if the patient has atrial fibrillation, we need to treat them with anticoagulants, right, sir?
I'm not able to get the voice is not clear, sir. There is some disturbance, so I'm not able to get.
So the
what
question was the in stroke, in a
Yeah.
patient who presents with stroke, if he or she has an underlying atrial fibrillation, should we treat or not? Definitely, we need to treat atrial fibrillation with anticoagulants.
Exactly, sir.
Can we differentiate between WPW pattern and WPW syndrome on the basis of ECG? It's asking whether the pattern and the syndrome is different or the same. I didn't understand the question. If you can.
Yeah, I'm also not able to comprehend because I have not heard like WPW pattern. WPW syndrome is a entity,
Yeah,
but
we
as
can have
such
different.
pattern.
So what he's trying to ask is that in WPW syndrome, we can have different patterns. The patient may show a normal ECG sometimes, but
Yeah,
occasionally he might show an aberrancy, and occasionally he might show an arrhythmia.
yeah,
So there
that
is
is
one
true.
question on differentiating between digitoxin effect and digitoxicity. It's an interesting question. This is asked in the exam also. Digitalis effect is, there are certain changes in the ECG which can only predict that there is some impact that this patient is on digitalis. They are benign and they do not depict anything. While in
The
patients,
classical right is displays effect, which all of us teach undergraduate and postgraduate students.
toxicity will manifest as ventricular
Yeah.
ectopics, increase the toxicity. They can have arrhythmias, they can have AV nodal blocks. So all
Exactly. The toxicity is known to cause each and every known arrhythmia. Digital's toxicity can create each and every arrhythmia which we have read and which we know. So it is well known that digital's toxicity can be sometimes or the other responsible for any kind of arrhythmia. But as far as the effect is concerned, it doesn't cause much. It is only the
hockey
ST
stick
segment.
appearance which we see in the.
Yeah. It becomes right appearance, tick-like
Question on,
appearance.
please repeat the strain pattern. The strain pattern is seen in patients with classical left ventricular hypertrophy, which fulfill the criteria, ECG criteria, which Sir has very clearly pointed out. So there in these patients, you might find some STT changes in the pattern. If there is a left ventricular hypertrophy, then you might see STT changes in V5, V6, or AVL, and these are known as strain patterns.
Yeah, exactly. Because I have already told you if step 1 and step 2 they have been fulfilled, then only step 3, that is presence of these changes to be labeled as LV strain, should be considered. If 1 and 2 are not there, then you cannot consider that these are because of strain, and that is
There's one
precisely what
question
we
that I have understood. If you have understood Salvador Dali mustache, this must be a name given to any specific condition. I am not aware of that. Dr. Usha, they are ready to all panelists. Salvador Dali mustache. Have you heard of this term, sir?
This I have not heard.
And we don't know. Actually, you can find it on the Google. And then I think most of the questions have been answered. So I think your talk has given a lot of information on ECG makers, which everyone should be aware of, especially the young attendees who are becoming physician, you are the ones who are going to be in ER and see the patient first time. But I think more important is to take the help of the other, the clinical symptoms, the ECG changes, and the help of a biomarkers, so that you are able to come to a conclusion. And in the presence of a doubt, then of course echocardiography, which will give you the final version of whether we are dealing with acute coronary syndrome or not. I think with this we will finish the presentation. Though we were what he's saying is mustache sign is inverted tick sign thing in this. Oh, that hockey, we used to call it as hockey stick sign. Now this is a mustache sign and inverted tick sign seen in digitalis applications. So that's the same thing which we were talking about. And with this, I think we will conclude the session. And thank you very much, sir. Personally, I've also learned a lot from your presentation. And
Thank you so much, sir. Thank you.
And we would like to request you to have one more class again when whatever talk you want to give after 3 or 4 weeks.
Okay, sir. I will be in touch with you, sir. I will be definitely interested, and I'm really enjoying this part of my teaching. Thank you so much.
Thank you, and over to you, National Board, for the conclusion.
Okay, thank you, and good night, sir. Good night.
Thank you so much, sir, for the wonderful session.
Okay, thank you.
Thank you, sir, for joining us.
Okay, thank you. Thank you.
So they want a class on ECG also. They want a class on ECG, so we'll have it maybe some other time.
Okay, thank you.
Thank you, sir.